Dr. Chavi Gupta has completed her MBBS from SMS Medical College, Jaipur. After that, MD from University College of Medical Sciences and DM in Infectious Diseases from All India Institute of Medical Sciences, Delhi. At present, she is working as consultant in the Central Hospital, Delhi, and now she is more involved in the clinical microbiology. Now I will request Dr. Shukla to introduce our speaker.
Yeah, good afternoon, everyone. And I thank Dr. Neeraj and Melap team to have invited me as the chairperson. I also send my wishes to my co-chair, Dr. Chavi. She was our student and now she has scaled up in her career so much. We are so proud of her today. And it is actually for India also, it's a very proud moment that we have, 2 vaccines which have been rolled out yesterday. And but how did that happen is what I think we are going to hear from Shabnam, Iyer. So this is all that little tormentor which had created havoc in our lives. So the pandemic COVID-19 is was a turning point in our lives, where I just take 1 minute in this because at that time we were all pushed, especially in India. The laboratories, many of our labs were not ready to take up this diagnostics for viral diagnosis. And when we were all pushed to start with this viral diagnostics for looking for SARS-CoV by real-time PCR, the other diagnostic laboratory took a toss completely. So I think, and the infection control team and the clinicians were all busy, taking protocols or writing down guidelines for preventing transmissions or infection from one COVID patient to another. And in that, I think we lost the actual protocols, the diagnostic approaches to fungal, to bacterial infections. And so probably this, at a later months, we realized that probably these also should be looked into. And we need to find out whether the mortality is actually due to COVID or is it because of the secondary infection. So very rightly, we have this title today, which Dr. Shabnam Iyer is going to take. She is a consultant microbiologist from Royal Berkshire NHS Foundation Trust UK, and we are very pleased to have her. And Adam, you can start your topic on reinfection and secondary infections in COVID.
Thank you very much. Thank you very much for the introduction, and thank you very much for the invitation to speak on this event. And it is a huge pleasure to be speaking to this, faculty and this audience. Right. As Dr. Das actually mentioned, I'm a consultant microbiologist at the Royal Berkshire Hospital in Reading, which is in the southeast of the country. The country, that part of the country is grappling with the new variant of SARS-CoV-2. We all agree that this is the greatest pandemic of our generation, whilst the global community is trying to contain it by launching its mass vaccination programs. And amidst the threats posed by the new variants, there are lots of questions that we also need to address, whether the natural infection or the immunity conferred through these vaccines is going to protect us against the infection, against the reinfection. And equally, as our hospitals are filling in with patients and the clinicians are trying to save lives of patients with COVID-19, and we also need to understand whether our pharmacological interventions, whether it is in the form of steroids or other immunosuppressive therapy, including routine use of broad-spectrum antibiotics, are we unintentionally fueling another pandemic in the background? And that is the pandemic of antimicrobial, basically growing threat of antimicrobial resistance. So with this premise to answer some of these questions, the brief for this morning is to actually talk about reinfections and secondary infections in COVID-19. Here I present the outline of my presentation, which I would like to cover over the next 15 to 20 minutes, taking you through the definition of reinfection, diagnosis, what we know of the current epidemiology of reinfection, and how we manage these. And likewise, for secondary infections in COVID-19, what is that we know about the current epidemiology, the microbiology, how to diagnose and manage these infections. And I intend to finish my presentation with a few sort of take-home messages. So what is reinfection? Reinfection is recurrence of a new infection following resolution of initial infection. So if a patient actually had COVID-19, which is symptomatic SARS-CoV-2 infection, there's a symptom-free period between the initial and the subsequent infection. And if a patient has been picked up on routine surveillance through RT-PCR, a reinfection means it is repeat positivity after a brief negative, period of negative RT-PCR test. But the challenge really is, how do we differentiate reinfection from persistent infection, which is possible or which is actually seen in patients whose immune system is not robust to clear that infection, clear the primary infection. And the low-level viable viral shedding continues a lot longer compared to those in immunocompetent individuals. And then the challenge of prolonged PCR positivity. The PCR positivity that persists for a very long period of time, and it has been detected up to 104 days. PCR, reverse transcriptase PCR or real-time reverse transcriptase PCR is currently the gold standard to diagnose acute infection, but it is not free from its own challenges when it comes to diagnosing reinfection. As I said, one of the biggest challenges is the persistence of PCR positivity for a prolonged period of time. So it may be intercepted with periods of intermittently negative and then reappearance of positivity. So whether that is reinfection or just the persistence or prolonged persistence of RT-PCR positivity. As you can see from this graph, there's a long tail, but beyond day 7 or 9, viable virus has not been cultivated. So although viral RNA may be detectable for a prolonged period of time, which varies from individual to individual, but the viable virus, the one that is responsible for infectiousness for transmission, has not been cultivated in immunocompetent individuals beyond 7 and in some published reports beyond 9 days. So persistent RT-PCR positivity does not equate with transmissibility because it does not equate with viable virus. So establishing reinfection of SARS-CoV-2 is quite a challenge. So it is not a simple feat. So for that purpose, Center for Disease Control in US has proposed its investigative criteria. In August of 2020, CDC has recommended against retesting previously positive immunocompetent individuals with PCR within 3 months because the reinfections are rare in this period. So, but this CDC criteria is quite prescriptive. It actually, there's an expectation that the institutions or wherever the individual has been tested or diagnosed with the use of RT-PCR, they will actually save their primary or initial infection sample because it is dependent on the availability of the paired sample from the initial and the subsequent sample. And then retesting these samples with RT-PCR. So repeat positivity on any approved nucleic acid amplification test or RT-PCR, which is the most commonly used PCR methodology for diagnosis of these infections, beyond 90 days with a low CT value, which is suggestive of high viral load, actually makes one suspect whether this is a reinfection. However, in an individual, a repeat PCR positivity at that high viral load level with a CT value of less than 33 in less than 90 days, between 45 to 89 days after the initial infection, with a compatible clinical illness or a known contact with a confirmed case of PCR, also makes one suspect whether this repeat positivity at such a high viral load is actually suggesting reinfection. However, the gold standard for confirmation of reinfection is through whole genome sequencing. and to establish whether the initial infection and the subsequent infections are caused by different strains. Because this virus accumulates mutations at the rate of at least 2 nucleotides per month, so we expect the difference between the initial infection, between the strain causing initial and the subsequent infection, in order to confirm that this is reinfection, difference between the two strains more than 6 nucleotides. Other alternatives which can be used to detect the viable virus are growth of the virus in viral culture, which most of the facilities do not actually have because it requires biological safety cabinet containment level 3 and or subgenomic messenger RNA analysis, because we want to detect whether the virus that is detectable is actually replication competent. There can be supportive evidence that can be obtained through the serologic evidence, and that is through the rising titers of the SARS-CoV-2 proteins, particularly the rising levels of neutralizing antibodies to the anti-spike or anti-spike protein antibody in the absence of vaccination. And some of the research facilities may even have assays to quantify SARS-CoV-2 T cell responses in the form of CD4 and CD8. Some reinfections are expected, as is the behavior from the close cousins of SARS-CoV-2 in the viruses that cause common cold causing alpha coronaviruses and a couple of beta coronaviruses. These have been reported at a much lower frequency, about 4 to 21%, and we all know that the immunity from the SARS-CoV, from the seasonal coronaviruses is short-lived. However, if you actually compare the number of infections that we have actually seen, globally approaching to nearly 1 billion, the number of reported reinfections which have been published or undergoing investigations is just a handful of cases. There are 7 confirmed cases which have been published, and in total less than 20. So that actually makes us really think whether these reinfections are truly sort of lower number, or there is an element of underreporting, because as I mentioned, the CDC investigative criteria is quite prescriptive. It is quite stringent. It requires the availability of the paired samples from the initial and the subsequent episode of infection. And plus, it requires the availability of the genomic analysis. We all know in the first part of during the first wave of the pandemic, as Dr. Das also alluded to, we were not quite prepared. Our diagnostic, basically repertoire was not quite ready to face the challenge posed by this pandemic. So many of the initial infections were not diagnosed. They were epidemiologically diagnosed, or they were not, all of them were not diagnosed with the help of, RT-PCR. And quite a few of the patients were actually presenting much later in the illness, where the RT-PCR may not be positive, but these patients definitely had clinical, COVID. And the diagnostic basically was limited. The access to the diagnostics was also limited, and so there was limited accessibility of diagnostics. However, that said, there is now evidence from 2 large longitudinal cohort studies recently published from UK, and these are through the active surveillance of the healthcare workers who are at a much greater risk of healthcare associated COVID-19 or SARS-CoV-2 infection. A large group of healthcare workers have been followed up, and to see how many of those who had antibody at the baseline then went on to develop SARS-CoV-2 RT-PCR positivity if they are asymptomatic or clinical COVID with symptomatic infection with SARS-CoV-2. The first study was published very recently in the New England Journal of Medicine on 23rd of December, and that involved more than nearly 12,500 healthcare workers. And over a 6-month period, they analyzed the results, and they found that out of 1,265 healthcare workers who were antibody positive at baselines, there were no symptomatic infections, and there were only 2 asymptomatic infections compared to 223 infections which developed in healthcare workers who were antibody negative at baseline. So this study then went on to conclude that the SARS-CoV-2 antibody does protect against reinfection for at least 6 months, because that has been the follow-up period. And a similar study, but a much larger cohort of healthcare workers who have been similarly followed up following their assessment of their serostatus at baseline, and this time involving nearly 21,000 healthcare workers, out of which nearly 6,500 actually were antibody positive at baseline, and 44 potential reinfections have been identified, which are undergoing further evaluation with genomic analysis. And if all of these are then confirmed to be true reinfections, even then the efficacy of natural infection imparted immunity is 83%. And if only 2 of the probable infections are confirmed, then it actually does confirm that the reinfections are going to be a rare event following natural infection. And it will actually impart, basically immunity, at least in the short term, for 6 months, because that has been the follow-up period. As I said, just a handful of cases have been reported in literature. And if we actually look at the clinical course of these infections, majority of these have been asymptomatic, apart from latest 3 cases. And one of the latest case actually has been with the SARS-CoV-2 new variant in UK, in the southeast of London. Majority of the cases have been mild or asymptomatic. And this latest case of SARS-CoV-2 variant, which has been detected in the southeast of London, is in a 78-year multimorbid hemodialysis patient who did not have any other significant immune compromise. The initial infection, which was in the first wave of the pandemic, was a mild illness, and the subsequent infection 8 months later was a critical illness. And we basically hypothesized that this could be due to immune enhancement, although the reinfection was seen in the face of the detectable anti-SARS-CoV-2 antibody. Now, that said, majority of the anti-SARS-CoV-2 antibody detection methods used in the UK actually look for total antibody, and that total antibody responds to N protein. And there are very few assays which specifically seek for anti-spike antibody response. So this is basically the current state of knowledge with respect to reinfection. But we need to be very cautious whether we have got suspected or confirmed reinfection. Although there is no documented current evidence of onward transmission from these reinfected cases, we manage these reinfected cases as potentially infectious with repeat isolation and contact tracing, and the same epidemiological control measures as for primary infections, with universal masking and social distancing in place. And we also offer vaccination, which may actually work like a booster response. So without further ado, this is what I know and what I've shared with you, my current knowledge or current state of play with respect to reinfection. We also now want to actually talk about how we actually manage the infections in patients who are admitted in the hospital, who we are trying to save lives with, with a number of pharmacological interventions, which involves use of high-dose steroids, which has shown to save lives in patients with severe and critical COVID, and some of the newly introduced or newly approved immunosuppressive therapies for which newer evidence has become available. But something that we have always taken for granted is the use of antibiotics. Despite knowing that SARS-CoV-2 is a virus and the COVID-19 pneumonia or pneumonitis is viral infection, what we have actually seen in the past 1 year, all hospital admissions with COVID-19 have all been treated with broad spectrum antibiotics, and for which we have not actually paid much attention to. We have not done much evidence appraisal, whether this is an evidence-based approach for managing secondary infections, or co-infections in these patients. At the same time, when we want to do no harm to our patients, we should be focusing, what is the evidence base for our current approach of managing these patients. Little is known about the temporal relationship, when do these infections, start in a patient with COVID-19, whether they have been present at the outset when the patient presents, so these are like co-infections, or they develop subsequently during the course of hospitalization or later on in the course of the illness. So various terms have been used interchangeably as co-infection or secondary infection, but I prefer the term concomitant or intercurrent infections. Most of our current knowledge has been from the initial studies which have been published from China. And we know that the diagnostic capabilities and the diagnostic protocols vary between different countries. And in the first wave, even in the countries where they had the diagnostic capability and diagnostic repertoire to diagnose secondary infections, the diagnostic workup of these patients was very limited because of the risk of transmission to the healthcare workers. Diagnostic sampling was limited, and we were actually we were not even thinking of focusing on other concomitant infections in this group of patients. However, secondary infections have been infrequent in hospitalized patients with COVID-19. In a living meta-analysis, which is updated every 3 months, but currently the data is available in the public domain only in the first wave of the pandemic from the 24 studies involving 3,338 patients, which actually looked at the prevalence of bloodstream infections and respiratory tract infections. The overall prevalence of secondary bacterial infections was less than 10%, 6.9%. Community onset co-infections were found in 3.5% of patients and secondary bacterial infection in 14.3%. Infections were more frequent in patients who were admitted with severe and critical COVID. But what is striking is majority of them, 3/4 of those patients, went on to receive antibiotics. Since the publication of this living review, and which, as it says, it is living, it is being updated, there have been 2 further studies which have actually corroborated that the infections, secondary infections, are very low. Now, that said, bacterial infections are more common in critically ill patients, but they do carry very high mortality. And there are some predictive risk factors that you can actually focus on which patient groups to target broad spectrum antibiotics to. Patients who are in respiratory failure, who require ICU care, require emergency, require ventilation, and have got severe lymphopenia, have got underlying comorbidities. And as they spend longer in the hospital, they are exposed to the risks of healthcare associated infections. The most common infections, secondary infections that we see in hospitalized patients are the ones which are, lung infections like hospital-acquired pneumonia or ventilator-associated pneumonia or bloodstream infections. And the common pathogens are the same: Staphylococcus aureus for bloodstream infections, or Coagulus negative Staphylococci, or E. coli tops amongst the gram-negative pathogens. And we do see mixed infections, and majority of the organisms that we recover from the bloodstream of these patients are deemed to be secondary to the primary focus in lung. And we all understand from what we know from influenza, it is the primary disruption by the viruses at the local mucosal level that provides a selective benefit for these local pathogenic bacteria to invade, translocate, and cause secondary bacterial infections. But equally, the longer these patients actually spend in the hospital, because these patients admitted in the hospital with moderate to severe and critical COVID are faced, with a number of healthcare interventions involving invasive devices, broad spectrum antibiotics, and as I said, use of some of the newly approved immunosuppressive therapies, that actually further increases the risk of secondary infection. The microbiology, as I said earlier, varies with the local protocols, local antibiotic policy, but using a real-time PCR, this group has published the findings that 94, they could actually detect a pathogen, a pathogenic microorganism in about 95% of patients who were with COVID-19. And they tried to categorize the distribution of the pathogens based on the severity of illness. Now, whether just the mere presence actually reflects infection or colonization, that is something for us all to debate. Bacterial pathogens are the commonest, followed by viral and fungal pathogens. And the common pathogens, the common offenders are the same: Streptococcus pneumoniae, Klebsiella pneumoniae, Haemophilus influenzae, E. coli, Staph aureus, and a fair few Aspergillus infections as well. Now, Pseudomonas aeruginosa, human adenovirus, and human rhinovirus and herpes simplex viruses have, this group only detected in patients who were symptomatic, but regardless of their severity. But what is again striking is the co-infection with other viruses like influenza and influenza B viruses, despite the sampling being done in the flu season, were rare. We understand invasive, we have seen influenza-associated aspergillosis, and infections with other mycobacterial pathogens have also been described, but these are, again, few case reports. But what is really to bear in mind is, as we roll out new immunosuppressive therapy, is the reactivation of some of the other opportunistic infections like CMV, EBV, herpes, and strongyloides, HIV, and pneumocystis. When it comes to diagnosis of these secondary infections, it is very hard to diagnose these infections based on the clinical symptoms alone, because the clinical symptoms and signs overlap, and so do the risk factors which predispose to infections with influenza or with SARS-CoV-2. So none of the laboratory or the imaging findings are deemed, basically specific or pathognomonic of COVID-19. So we are heavily reliant on our diagnostic testing. Because pneumonia is a clinical syndrome caused by a whole range of pathogens, viruses, bacteria, fungi, and some of the parasites as well. So the newly developed syndromic multiplex panels are hugely beneficial. And it again depends, on the availability and affordability. But some of the simple tests which have stood the test of time, which are, point of care as well, urinary antigens for pneumococcus and Legionella, some of the biomarkers which help us rule out bacterial infections or for early stopping antibiotic therapy, and some of the other biomarkers for fungal infections like serum beta-D-glucan and bile-galactomannan to diagnose invasive aspergillosis and for the diagnosis of PCP. Now, this seems like a very busy slide, but what I'm trying to actually present is this is how our diagnostic, basically clinical algorithm for managing a patient with community-acquired pneumonia is. And on this side, as you can see, the list of investigations that are actually ordered in a patient who is diagnosed on the chest X-ray based on the clinical symptoms and signs with community-acquired pneumonia. If they are septic, we send 2 sets of blood cultures, we send nasopharyngeal swab. And in flu season, we also request for flu and RSV PCR. And in patients who have got underlying chronic lung disease as COPD, extended viral testing is requested. But in patients who are admitted in the hospital for care of pneumonia, all these patients actually get urinary antigens for pneumococcus and Legionella. If they are productive of sputum, then we also try to culture those in the lab. And depending upon the urgency of the need for the test, we can also subject these to a multiplex, PCR. But all these tests are requested only in the clinical context, only if a patient is suspected to have clinical symptoms or signs suggestive of pneumonia, not out of context, because these are very expensive. And this is the molecular platform, BioFire, that I mentioned. Within just a matter of 45 minutes, with minimal hands-on time, the whole range of viruses and bacteria that can be detected in a sample that is collected in the context of a patient who is suspected to have either hospital-acquired pneumonia or ventilator-associated pneumonia. These tests are performed in ICU, and an intensivist suspects a patient actually has got either ventilator-associated pneumonia or hospital-acquired pneumonia, and the appropriate specimen is collected and result is promptly acted upon. And this is our algorithm where every patient who is admitted, they get the serum procalcitonin ordered at time 0. And if the level is below 0.5 nanograms per ml, the first dose of antibiotic is all that they receive, and they do not receive subsequent antibiotics. And if a patient then deteriorates, another PCT is requested. If the two values are still remain low, no antibiotics treatment is initiated. Whereas if we see a 5-fold increase in the serum PCT value, we prescribe broad spectrum antibiotics. And that is our way to steward the use of broad spectrum antibiotics. But if we do find dual infections, then we appropriately target with antiviral if we find influenza with oseltamivir. But what we have learned, from our experience and from appraisal of the evidence, that the current data does not support routine use of broad spectrum antibiotics. And as I said, by giving broad spectrum antibiotics, we do not want to be unintentionally fueling another epidemic or pandemic, global pandemic of multi-drug resistant organisms. Multi-drug resistant organisms are independent predictors of poor outcomes in these patients. And similarly, if we do find, based on our biomarkers, any evidence of fungal infections, we target that. So this is my final slide, and with some take-home messages. Current evidence suggests that SARS-CoV-2 reinfections are an exception rather than a rule, at least in the short term. So immunity imparted through natural infection or through vaccination, we know at least will protect us in the short term, and time will tell how long this is going to last. Active surveillance of reinfections is required to monitor efficacy of vaccines. Confirmed community onset bacterial co-infections are rare. Routine antibiotic treatment of hospitalized patients with COVID-19 is not recommended. Rather, targeted therapy supported with better diagnostics and prognostics is what we recommend and what we use. And prospective surveillance of secondary infections is urgently required to inform our current antimicrobial policy and to steward the use of broad spectrum antibiotics so that we can contain another epidemic brewing in the background of multi-drug resistant organisms. Thank you very much for listening, and I'm happy to take